this video, we'll briefly discuss the Prism Adaptation test. So for the Prism Adaptation test, we use it generally preoperatively, and we are trying to see or assess whether the patient has potential for BSV. And it also provides us with the maximum angle of deviation, so it can give us the target angle for surgery. So overall, it can provide us with a prognosis for surgical outcome, and we know whether we may achieve a functional outcome. Now, in terms of selecting patients for the Prism Adaptation test, generally they will have an acquired ESO deviation, and they will have a deviation that does not exceed 40 diopters. They should have generally relatively equal vision, and you'd like a non-specific stable angle deviation. Okay, in terms of performing the test, what we're doing here is we're essentially firstly assessing the deviation and measuring it. And here we have an example of where a patient has a left esotropia of 25 diopters. And remember that 25 diopter base out PCT means that the distance between the fovea and the CIP is 25 diopters. And essentially what we do is we put before the eye a prism that overcorrects the deviation. And so you'll take a frenel and pop that in front of the patient's glasses, or if they don't have glasses, you can take a pair of planos and add the frenel in front of that. So with the overcorrection, what you'll see is that you'll pass the fovea and end up putting the image on the temporal retina. This will elicit diplopia, cross diplopia, because we're on temporal retina. And the reason why we overcorrect and elicit diplopia is because diplopia drives fusion. So what we're trying to see now is what's the motor response to this overcorrection? Will the patient fuse it? Is there a potential for BSV? Now, when we perform this test, we leave the prism on for at least a couple of hours, and it may be that you end up leaving it for a week if necessary. But within those 2 hours, you can review them and see what have they done with this prism in front of their eye. So the patient returns, and there are 4 possible responses that the patient can give you. The first is that when you assess the patient with the prism, or with the glasses on and the frenel on there, nothing has changed since putting on the prism. So when you assess them, there's still an overcorrection, and so if you do a cover test on this patient, you'll find that you're getting an Esotropia. This is actually a favourable response. It's telling you there's no potential for BSV, but what it's also telling you is that the outcome for surgery will be relatively favourable in that they won't become a large angle ET again. Okay, another response is that they fuse the diplopia and they regain BSV, and essentially the visual axis becomes straight. So what you see here is that the image now falls on the fovea, and if you did a cover test now with the frenel, what you would see is orthotropia. Now, you'll need to prove that this patient has BSV, and so a test like Baggellini striated glasses test is good. You'd put Baggellini striated glasses in front of the eyes with the frenel there, and they should be able to give you a cross indicating that what you have achieved is orthotropia and BSV, and this is obviously a favourable outcome with a potential for BSV. Okay, another outcome is that with the frenel prism, the patient becomes microtropic. So they have a small angle strabismus, so they don't actually have straight visual axis. If you did a cover test on this patient, you would find a small esotropia, a flick ET. But if you were to give them a Baggellini glasses test, what you would see is that they give you a BSV response, so they give you a cross. So in this instance, this is also a favourable outcome where you're going to have a microtropia with BSV as a potential outcome of surgery. Okay, the last outcome is unfavourable, and what happens here is that the patient does what we call eats up the prism. So with the frenel there, they return to their original angle of deviation. So if you did a cover test here, you would find that you have the original ET, that 25 diopter ET. This essentially indicates that the patient likely has anomalous retinal correspondence, which is driving this anomalous movement and for them to eat up prism. this is generally going to give you an unfavourable surgical outcome. Okay, so they're the 4 responses from the Prism Adaptation test that you can utilise preoperatively to give you an understanding of the potential for BSV.